myself, Sarah Gordon, Megan Cole, and Paul Schaefer, all assistant professors in the Department of Health Law, Policy, and Management at the Boston University School of Public Health. Thank you so much to everyone who is tuning in today and for your interest in learning more about the important role of Medicaid policy in shaping the public's health. Before we turn to the lightning talks, I want to spend a moment talking about why we are building a research hub that is focused on the Medicaid program specifically. So why Medicaid, or put another way, why should you care about Medicaid? Medicaid is a state-federal partnership program that provides health insurance to over 70 million people. Medicaid touches most American lives. Many of us or our loved ones will rely on it at some point over our lifetimes, as Medicaid is a primary payer for births, children, mental health care, and long-term care in the US, and is the largest source of funding for medical and health services for people with low incomes in the US. Qualifying for Medicaid is dependent upon your income, your eligibility category, and the state you live in. So for example, children living in households with incomes up to 216% of the federal poverty level qualify for Medicaid in all states. Whereas if you're a childless adult in a state that didn't expand Medicaid under the Affordable Care Act, then no matter how little income you make, you do not qualify for Medicaid. Medicaid policy decisions impact key cross-cutting areas of health research that are the focus of many of our colleagues here on the BU campus, including mental health and substance use, healthy aging, maternal and child health, and racial, ethnic, and socioeconomic inequities in health outcomes. Medicaid is a key financer of the US healthcare safety net and therefore intersects with systematically marginalized populations in the US who are affected by Medicaid policies related to eligibility, enrollment, benefits, and delivery systems. But despite the important role that Medicaid can play in improving health and the critical need for evidence to inform decision-making across many unique different programs, Medicaid research can be challenging and impose a high barrier to entry. So one reason for this is that Medicaid programs are run primarily at the state level, which creates significant heterogeneity in policies, benefits, and care delivery models across states that are determined in part by complex legal and political contexts. Second, Medicaid data can be very hard to obtain. If accessed on a state-by-state basis, it can require partnerships with state Medicaid programs, or at a national level, data can be very expensive or just time-consuming to master. So our lab pools resources, fosters collaboration, and tries to demystify Medicaid research. I will now turn it over to Dr. Cole to describe our lab's mission, our members, and the work that we do.
Great, thank you, Sarah. And I have a bit of an echo. Can others hear that? There we go. Thanks. So I'll be talking just a little bit about the BU Medicaid Policy Lab, who we are and what we do. And I'll start off by talking about our mission, which is really threefold. And first, at the lab, we aim to understand how both Medicaid policy and care delivery models impact things like health insurance coverage, access to care, quality of care, health outcomes, and equity in Medicaid populations. And these topics really overlay a lot of the empirical work that we do. And then we use this work to inform policymaking and practice with evidence. So we do this through multidisciplinary collaboration. So our research teams are often made up of Medicaid experts from many different fields. We also partner with state and safety net health systems, where we're especially excited about expanding some of these partnerships going forward. And then we also do a lot of dissemination activities, and this includes things like drafting amicus briefs. And then finally, we're really excited to be a resource to the research community studying Medicaid. And this includes anyone for whom your research might otherwise intersect with Medicaid or Medicaid populations. And as I mentioned, we're a very interdisciplinary group made up of both faculty and students from across Boston University. We're comprised of health services researchers, health economists, legal scholars, physicians, and political scientists. And just some of our many faces are shown here. And then the co-directors of the lab include Sarah Gordon, Paul Schaefer, and myself. And if you ever have any questions about the lab or want to reach out, you can reach out to any one of us at any time. And then across all of the work that we do, it really spans the intersections of Medicaid and a lot of different topics. And those topics range from things like Medicaid expansion to value-based care to COVID and equity. And you'll get a little bit of a sneak preview about some of our work in these topic areas when we go through our lightning talks today. And as Sarah alluded to earlier, one of the real kind of motivators for our lab was really data and data sharing. And within the BU Medicaid Policy Lab, we have access to a number of different data resources. These include national Medicaid claims data, such as the CMS TMSIS data. We also have a number of different all-payer claims databases in-house. We have HCUP state inpatient and emergency department databases, as well as national data sets on federally qualified health centers and a number of other data sources. This isn't an exhaustive list, but it kind of gives you a flavor for the types of data that we use and have available. And then funding for Medicaid Policy Lab researchers come from both public and private funding organizations, and this includes the NIH, in addition to other private organizations like the Commonwealth Foundation and the Robert Wood Johnson Foundation. And then finally, and maybe most importantly, we're particularly excited to collaborate with you, whether that's through research collaborations or other types of partnerships. We do have monthly lab meetings, so we meet the fourth Tuesday of every month. We also maintain a Medicaid Policy Lab listserv. And if at any point you'd like to learn more, you're interested in collaborating, please do feel free to reach out. Our email address is listed there, and you can also learn more about us by visiting our website, which is listed here as well. And with that, I will turn it over to Dr. Schaefer.
Thanks, Megan and Sarah, and thank you all for being here. What I'm going to do is introduce our lineup of speakers for today for our lightning talks. Before I do that, just a brief comment on the format. So these are going to be short talks, 5 to 7 minutes, just meant to give you a brief glimpse into the type of work that we do. So they're going to be pretty light on methods, and they're all going to be formatted around a single number as a starting point, some important piece of Medicaid policy or Medicaid outcomes that we care about. We're going to be holding questions at the end, but please put those in the Q&A, and once we get through the lightning talks, we will use whatever time we have left to have a discussion of your questions. So with that, I will go ahead and introduce our speakers. First up is going to be Dr. Nicole Huberfeld. She's the Edward R. Utley Professor of Health Law at the BU School of Public Health, as well as a Professor of Law in the BU School of Law. She's going to be discussing Medicaid expansion and Medicaid demonstration waivers from the lens of the legal side of things. Following her will be Dr. Sarah Gordon. She's going to be discussing Medicaid eligibility and postpartum care. Following her will be Dr. Megan Cole, who will be discussing the critical role that federally qualified health centers play in the quality and access to healthcare that is necessary for Medicaid populations. I'll be going forth, discussing some recent work with the state of North Carolina around the intersection of unemployment, Medicaid enrollment, and social vulnerability during the COVID pandemic. And then last but not least, one of our amazing PhD students, Samantha Audie, will be sharing some work on an emerging alternative payment model for high-cost drugs in Medicaid, subscription-based payment models for hepatitis C drugs. So we've got a really great lineup for you, and excited to kick it over to Nicole to get us started.
Thanks so much. Thanks, Paul. Thanks, Megan. Thanks, Sarah. It's really exciting to be with everybody today and to see the great number of participants in our audience. And we look forward to the Q&A at the end. It's just taking a second for me to get control of the screen. So There we go. Okay, great. So as Sarah said in her introduction, Medicaid is a 56-year-old program that offers federal money to states to cover medical care for low-income individuals. And I think someone else is controlling my screen. There we go. Congress designed Medicaid to address poor patients' needs by including 4 core protections that secure coverage and care for Medicaid enrollees. So my first number for you today is 4. So why 4? Well, these 4, there we go. These 4 core benefits and protections are actually quite important to understanding the legal structure of Medicaid and what Medicaid looks like for the people enrolled in it, in addition to how Medicaid operates for states. And this is also important to understanding the status of Medicaid and its role in health reform today. So the 4 core benefits and protections include special safeguards for low-income populations and their eligibility. Unlike Medicare, unlike commercial insurance, we have continuous open enrollment in Medicaid, as well as protections for things like postpartum care and newborn eligibility. We also have special services designed to meet the needs of low-income individuals. This includes things like non-emergency medical transportation, which typically is not covered by other forms of insurance. We also have strict cost protections to ensure that Medicaid remains affordable for low-income patients. And we have procedural due process protections, meaning that beneficiaries have strong procedural and other legal protections within the Medicaid program. This is important not only for beneficiaries, but also it's important to note that Medicaid is also an entitlement, a legal entitlement for the states that participate in the Medicaid program. So when the ACA was crafted, Medicaid was relied on heavily. When Medicaid became part of the near universal coverage scheme for the ACA, it was no accident because most of the people who were uninsured at the time that the ACA was created were in fact low-income workers. They were people who were low income, part-time workers who simply couldn't get insurance coverage elsewhere. Now, as many people remember, in 2012, the Supreme Court sort of upended the structure of the ACA and made it so that rather than the intended design of Medicaid expansion being required of states, states could decide whether or not they would expand Medicaid coverage. And so the Obama administration started to negotiate with states to try to get them into Medicaid expansion. And one tool, one dominant tool that they used for that is demonstration waivers. Demonstration waivers under Section 1115 of the Social Security Act give the Secretary of the Department of Health and Human Services the authority to approve demonstration projects proposed by states that assist in promoting the objectives of the Medicaid program. The objective of the Medicaid program is to furnish medical assistance, meaning to cover the people who are low income, who need medical care through their states. And so it's interesting because even as states slowly rolled out Medicaid expansion over time, Medicaid became one of the most important, most studied insurance rollouts, maybe in our history. And so as of now, there are more than 400 studies that show that Medicaid expansion improves individual and public health, supports providers, especially rural providers and rural hospitals, and stabilizes state budgets. In addition, Medicaid has the effect of doing things like improving access to care, improving health equity, and other important measures. Nevertheless, we have more than 2 million people who remain in a coverage gap. So this is my second number for you. This more than 2 million number is important because it has been this way through the Obama administration and through the Trump administration. So what is the coverage gap? It's people who can't gain insurance coverage through Medicaid because a number of states have refused to expand Medicaid coverage pursuant to the Supreme Court's 2012 decision. So what we see here is the states that are still holding out. It's 12 states. Most people who remain uninsured live in Texas, Florida, and Georgia. However, the other states are important to note as well. And it's interesting to note too why this is occurring. During the Obama administration, there were negotiations that were very active, very dynamic, making it so that states were sort of working their way toward Medicaid expansion. But one of the things that the Obama administration refused to approve was work requirements. And work requirements have sort of been one of the grand goals of conservative thinkers in the Medicaid program, but have never been approved by Congress. In 2017, Congress attempted to repeal the ACA. However, it was, as everybody knows, unsuccessful. Also, though, the Trump administration came into office deeply hostile to the Affordable Care Act and to social programs in general. And one of the first things that President Trump did was sign an executive order minimizing the ACA and its impact. So when Congress was unsuccessful in repealing the ACA, the Trump administration took work into its own hands and issued in early 2018 a policy that invited states to submit applications for demonstration waivers that would make it so that work requirements were imposed in Medicaid. These work requirements had never before been approved in Medicaid. And I published a piece, a New England Journal Perspective, that shows that work requirements are not only unlawful, but also not supported by the evidence, because most people who are enrolled in Medicaid who can work do work. And so the trouble, of course, is that the Trump administration had it backwards. It's not that you need to force people to work who are in Medicaid, but rather that health insurance supports people to be healthy so that they can work. Further, from a legal perspective, the work requirements impeded the 4 core protections that I mentioned to you a moment ago. They are predictably going to limit enrollment. And in fact, that's what we saw in Arkansas, the one state to both implement and enforce its work requirements. More than 18,000 people were disenrolled within a few months in Arkansas. We also know that these kinds of changes to the Medicaid program make it so that higher costs are imposed on people, so that one of those core protections is destroyed, and the social supports that make it so that Medicaid works for poor people are also impeded. Federal courts have agreed with this analysis, and in fact, every federal court to hear a challenge to the work requirements has said that the work requirements are procedurally flawed. And importantly, for the work that we're doing in the Medicaid Policy Lab, federal courts have relied on the kind of evidence that we are producing as a group, not just the legal analysis that I produced in the New England Journal, but also the kind of health services research, health economics research that we're producing in our policy lab. And so what the court has said is that when HHS approves a waiver, it has to be evidence-based. And the court itself relied on research and data that was part of the administrative record. So what will happen with the Biden administration? Well, President Biden, of course, was vice president when the ACA was created. He came into office and on January 28th issued an executive order indicating that the Affordable Care Act and Medicaid should both be strengthened during his term. We know that this became part of the American Rescue Plan, which incentivizes states to go ahead and expand Medicaid with a 5% increase in the funding that they'll get. However, we still have some question marks remaining because that is just a 2-year bump. And further, there is still litigation going before the Supreme Court, even though the Biden administration has now rescinded the approval for Arkansas, New Hampshire, Michigan, and Wisconsin. We don't know exactly where the work requirements legality will land. And so I'd love to talk about that more in the Q&A, but I'll stop there. Thank you, everybody.
Wonderful. Thank you so much, Nicole. So I'm up next, and I'm going to be talking today about the intersection of Medicaid and maternal health. The title of my lightning talk is Beyond 60 Days, Medicaid Eligibility Policies for Postpartum Women. So I'm going to start with the statistic of 22%. So 22% is the percent of Medicaid enrolled pregnant women in 43 states from 2015 to 2018 who were uninsured in the 2 to 6 months after delivery. So Medicaid finances 42% of all US births and the majority of births to low-income women. The program is therefore a key policy lever in improving maternal health in the US. Yet, current Medicaid eligibility policies can hinder continuity of care before, during, and after pregnancy. I just want to note that throughout this talk, I will use the term woman and women to align with Medicaid policy, but recognize that not all birthing persons identify as women. So the postpartum period is increasingly acknowledged as a critical time to address maternal health, as 1/3 of maternal mortality occurs in the year after delivery. This period of time also offers opportunities to address complications from pregnancy or childbirth, as well as promote women's physical and emotional health. So pregnancy-related Medicaid eligibility covers low-income women from from conception through 60 days postpartum, which you can see on this diagram I made here. The national median income eligibility for pregnancy-related Medicaid is 200% of the federal poverty level, which you can see here. So prior to conception and after 60 days, women can only be covered via Medicaid if they qualify through a different eligibility pathway, such as a low-income parent, for which the national median income eligibility is just 38% of the federal poverty level in states that have not expanded Medicaid, or as a low-income adult in states that have expanded Medicaid up to 138% FPL. For those who are ineligible to maintain Medicaid eligibility after 60 days postpartum, they must enroll in alternative commercial insurance or become uninsured. So this policy is a big contributor to that 22% figure of pregnant women in Medicaid who report being uninsured postpartum. So what are the potential policy solutions to this issue? So one is Medicaid expansion under the Affordable Care Act, which we just heard about in Nicole's talk. So this increases income eligibility for Medicaid up to 138% of the federal poverty level, which effectively narrows the gap between Medicaid eligibility criteria during pregnancy and then in the postpartum period. So in my work, my colleagues and I have showed that women in Colorado, a state that expanded Medicaid, experienced increased Medicaid enrollment and utilization of outpatient care in the 6 months postpartum compared to Utah, a neighboring state that did not expand. Importantly, after Medicaid expansion, women with severe maternal morbidity or very adverse pregnancy complications had nearly an additional month and a half of coverage over a 6-month period, indicating coverage gains were large among a very high-risk group. However, Medicaid expansion is somewhat of an incomplete policy solution because that 22% of women who reported being uninsured postpartum was from 2015 to 2018, a period during which the majority of states had actually expanded Medicaid under the ACA. So when you look at just expansion states, that statistic is 10%. The issue is that Medicaid expansion only covers people up to 138% FPL when pregnancy-related Medicaid eligibility is more generous than this. So it creates what we call an eligibility cliff at 60 days postpartum. So an alternative solution, excuse me, I just lost my. So an alternative solution would be to extend Medicaid eligibility for pregnant women beyond 60 days. So the American Rescue Plan, which was passed in March of 2021, actually included a state option for states to do this, to use federal matching funds to extend Medicaid eligibility for pregnant women from 60 days to up to 1 year. And already several states have signed on to do this option, and I think one has received approval. So also using data from Colorado and what's called a regression discontinuity design, I show in other work ongoing that eligibility for Medicaid beyond 60 days postpartum leads to longer durations of coverage and fewer disruptions in insurance over the postpartum year. So this figure shows the jump in postpartum coverage duration right at that 138% FPL income threshold that determines postpartum Medicaid eligibility. So those eligible for Medicaid have more months of coverage. So those who are onto the left-hand side of this vertical dashed line. And those who are ineligible, those who have incomes over 138% FPL, have fewer months of postpartum coverage with an average difference of about 1.3 months. Similarly, this figure shows coverage disruptions, which is basically a gap or a switch in health insurance during the postpartum year. So again, we see there's a sharp jump at that threshold of 138 that determines postpartum Medicaid eligibility. And those eligible for postpartum Medicaid have lower rates of coverage disruptions, and those ineligible have higher. So we also find that those who are not eligible to maintain postpartum Medicaid are more likely to transition to commercial or marketplace coverage, which is not surprising in and of itself if they lose their insurance, but they're also more likely to experience lapses in coverage when they do so. So these findings demonstrate that Medicaid expansion under the ACA improves access to postpartum care by narrowing the gap between pregnancy and parental Medicaid eligibility. However, postpartum Medicaid extensions may be a more complete policy option as they don't leave anyone out. There's no one who would be ineligible, who are enrolled in Medicaid during pregnancy, but then are ineligible in the postpartum period. but coverage is limited to a maximum of 12 months, so it's not as long lasting of a policy option. So there are trade-offs between these two approaches, but taking them together, this work suggests that states that adopt these policies will improve continuity of postpartum coverage for their Medicaid enrollees. So happy to talk more about any of this at the end. It was a very quick overview of two very complex studies, just hit the high points there, but I will now pass it over to, who's next here?
I'm next.
All right, I just gave you screen share, so hopefully that works.
Great, thank you, Sarah. So again, I'm Megan Cole, and today I'll be talking about the role of federally qualified health centers, or FQHCs, in quality of and access to care for Medicaid populations. And the number I'm going to start with is 40.4%. This is the percent of patients at FQHCs who were uninsured prior to Medicaid expansion under the Affordable Care Act. Now today, the majority of FQHC patients in expansion states have Medicaid coverage. And this number is so large because FQHCs serve low-income patients without regard for ability to pay. Today, about 50% of patients at FQHCs are enrolled in Medicaid, and about 1 in 4 are uninsured. And the majority of these patients come from racial and ethnic minority groups. So for these populations, FQHCs provide comprehensive, culturally competent, quality primary care healthcare services. And they provide these services to over 30 million people across the US. And this translates to about 1 in 11 people, 1 in 8 children, 1 in 5 Medicaid patients, and 1 in 3 people who are below the federal poverty level. So FQHCs really play a critical role in the US health system by providing access to care for populations who often would otherwise be without adequate access. And because nearly all patients served by FQHCs are either uninsured or covered by Medicaid, they're particularly affected by Medicaid policy, and they also play a really important role in improving health outcomes and equity for Medicaid populations. So today I wanted to highlight 3 policy relevant research areas in which I've been conducting research that really fall at the intersections of Medicaid and FQHCs. And I'll start off by talking a bit about Medicaid expansion under the ACA. Oh, I don't think I have control here. But there we go. And under Medicaid expansion under the ACA, FQHCs were particularly impacted by expansion, given that over 40% of their patients were uninsured prior to the ACA. So for FQHCs in Medicaid expansion states, what this meant was that those FQHCs received additional patient revenue for patients who newly gained coverage. And then for those newly insured patients, it also meant that those patients had better access to primary care, specialty care, and prescription drugs. So given this, we used data on a 100% sample of FQHCs throughout the US, and then over the longer run found that Medicaid expansion has been associated with gains in quality of care, including health outcomes, and increased provision of services. So for example, after 5 years, Medicaid expansion was associated with about a 3 percentage point relative gain in the percent of Hispanic diabetic FQHC patients with blood sugar control, as shown here, where the top blue line represents FQHCs in Medicaid expansion states. And we also found similar findings when looking at Black diabetic patients, where again, Medicaid expansion was associated with a relative increase in blood sugar control amongst patients served by FQHCs. And just to give a few more examples of the impacts of expansion, across the US, Medicaid expansion was associated with large increases in capacity to provide really important health services, including things like visits for substance use disorder, as shown here, where the rate of increase was greater for FQHCs in expansion states, as shown by the blue line. In addition to visits for anxiety and depression, as shown here, where again, the rate of increase was greater for FQHCs in expansion states. So next, I wanted to pivot to the role of FQHCs in Medicaid Accountable Care Organizations, or ACOs, which have been implemented to varying degrees in a number of states in recent years. And while some Medicaid ACOs have been more comprehensive in that they aim to address physical health, behavioral health, and social needs of patients, all ACOs aim to improve quality of care and contain costs. And a lot of FQHCs have been part of these Medicaid ACO models. And our work has found that in states, for FQHCs that are located in states with ACOs, or that participate in ACOs, they are 25% more likely to systematically screen patients for social needs, which has really important implications for actually meeting the social needs of patients and improving health outcomes. Our work has also found that Medicaid ACO implementation has been associated with things like relative improvements in cancer screenings, such as Pap testing and colorectal cancer screenings at FQHCs, as well as improvements in indicators of maternal health, including timely access to prenatal care and decreases in low birth weight amongst patients served by FQHCs. And then the final policy topic I wanted to highlight today is the intersections of Medicaid and COVID-19 in the context of FQHCs. So during COVID-19, FQHCs have played a really critical role in enabling equitable access to care for Medicaid patients. So FQHCs, both in expansion and non-expansion states across the US, were able to really rapidly transition to telehealth at the beginning of the pandemic in April 2020, as shown in the beginning of this chart here. And this allowed FQHCs to enable continuous access to care for their patients. And then in Medicaid expansion states in particular, which had more patient revenue at baseline, those FQHCs in those states were actually more quickly able to transition to telehealth in April 2020, despite the fact that non-expansion states actually had more telehealth capabilities prior to COVID-19. And then the final point I wanted to share here is that while there have been really vast racial and ethnic disparities across the US in terms of who's been able to access the COVID-19 vaccine, FQHCs have played a really critical role in enabling equitable vaccine access, as we've found in our recent data, where about 73% of all initiated vaccines at FQHCs have been with racial and ethnic minority patients. And the majority of these patients are from Medicaid populations. So what does all of this mean? I think there are really three major policy takeaways here. The first of which is expanded Medicaid eligibility is really critical to improved quality and access to FQHC patients. Second, expanded implementation of Medicaid ACOs, particularly those that address patients' behavioral and social needs, may also play an important role in improving quality of care at FQHCs. And then finally, states should continue to expand FQHCs as to improve equitable access to services for Medicaid enrollees. And this includes, but isn't limited to, COVID-19 access. And of course, all of this is dependent upon continued enhanced federal grant funding for FQHCs. And with that, I thank you for your time, and I look forward to your questions. And I will turn it over to Paul. Thank you.
Thanks, Megan. All right. Great talk so far. Really excited to be able to share some of the work that I've been doing recently directly related to the COVID pandemic. So as I mentioned earlier, this lightning talk is about a project that looked at the relationship between unemployment and Medicaid enrollment during the COVID-19 pandemic, with an overlay of equity, thinking about how this relationship varied by county level social vulnerability. So the number I am going to lead off with is $744, which might seem like a very random amount, but it is quite important, particularly in this context. So if you're a parent in North Carolina and make more than $744 a month for a family of 4, you don't qualify for Medicaid. And as a childless adult, there's no income-based pathway through which you can qualify for Medicaid in North Carolina because it's not an expansion state. And $744 is not very much, particularly in the context of a global pandemic when availability of resources and jobs is heavily constrained. So what was the motivation for this work? The unemployment crisis created by the COVID-19 pandemic and the shelter-in-place orders and shutdowns of businesses was already greater than the Great Recession after the first 3 months. And because of our dependence on employer-sponsored insurance, there was a potential uninsurance crisis brewing. Now, I will say many of the early projections early on in the pandemic proved to be much higher than what the data bore out in terms of coverage loss. But that said, for an individual or family who's losing coverage, whether those projections were too dire makes no difference to you. You're still dealing with the situation yourself. And racism affects everything, where people live, their jobs, their income, their health. North Carolina, as you can see in this snapshot from the Health Equity Report Card put out by the state a couple of years ago, there's a lot of red here. And this is African Americans, American Indians, Hispanic, and Latinx relative to whites. There's a lot of red here. There's a lot of room to improve. And North Carolina in particular has been lagging in shrinking inequalities and access to care. And one big reason for this is the lack of Medicaid expansion. North Carolina is the third largest state not to expand Medicaid. This is primarily a political fight between the governor, who is a Democrat, and the state legislature that is overwhelmingly conservative. That hasn't stopped the state from making some big steps. So Dr. Mandy Cohen, who came in as the Secretary of Health and Human Services in the state in 2017, after serving as Chief Operating Officer at CMS, has done an amazing job in terms of creating this buying health agenda. And for those of you who are really into Medicaid policy, you may have heard about the Healthy Opportunities 1115 waiver that North Carolina got within the last few years. And this my home state, has been developing this closing the feedback loop type system called NC Care 360, where not only are Medicaid enrollees given direction to different resources around housing and food and other things, but there's actually a mechanism by which those feedback loops can be closed, and we can track whether or not those resources are actually being provided versus just making a referral. So there have been some great steps besides Medicaid expansion, but obviously those eligibility criteria strictly limit who is getting through the door. So for this project, we partnered with DHHS in North Carolina to understand how Medicaid enrollment, utilization of care, and healthcare spending were changing in the state during the pandemic. This work was funded by the KB Reynolds Charitable Trust, and I'd be remiss to not thank my wonderful colleagues, David Anderson, Rebecca Whitaker, and Charlene Wong at Duke University, and Brad Wright at UNC for their collaboration on this project. All right, so we have two maps right here. On the left is the Medicaid enrollment rate, Medicaid enrollment per thousand population before the pandemic, so in February of 2020. And then on the right, we have a heat map of the CDC Social Vulnerability Index, which includes 15 different domains related to language proficiency, race, ethnicity, transportation access, education, employment, et cetera. These data are updated every 2 years. At the time we were doing this study, 2018 was the most recent data available. But you can see on these two heat maps that the areas of higher social vulnerability, these darker areas on the right, and the areas that had the highest rates of Medicaid enrollment seem to match up pretty well. And then we wanted to explore how did the differential impact of unemployment during the pandemic sort of interact with this existing situation? Were the more vulnerable areas getting connected to Medicaid? And so unemployment hit unevenly across the state. Statewide rose by about 140,000, but there were definite contrasts between urban and rural areas, and even going out deeper than that to the county level. There were some areas where the unemployment rate remained fairly flat or even decreased slightly during these first few months of the pandemic. And then there were other areas where it increased quite markedly. So we used data from DHHS as well as the Department of Commerce on Medicaid enrollment and unemployment to estimate what are called pass-through rates, essentially trying to quantify the share of the newly unemployed who are gaining Medicaid coverage. And what did we find? So overall, we found a statewide average pass-through rate of about 15%. I always struggle with how to frame this. It is encouraging because we found that more socially vulnerable counties had higher pass-through rates. So you can see the top 75 counties in terms of social vulnerability had much higher pass-through rates than the least socially vulnerable. Of course, there are lots of caveats to this. The least social vulnerable counties may have had, higher spousal incomes or access to other sources of coverage besides Medicaid. Perhaps they qualified for subsidies in the marketplace. So there's a lot of minutia here that I'm glossing over. But at least at a high level, it looks like there was sort of an equitable distribution to this. That said, just based on how low these pass-through rates generally were, we see that Medicaid was not really an option for most North Carolinians losing their job, primarily because of the lack of Medicaid expansion and the very low eligibility thresholds for parental coverage. And our results are very similar to those found during the should say Great Recession, not Great Depression, my apologies. There was a recent paper that came out from Benitez and colleagues that found an 11% pass-through rate in states with more restrictive Medicaid eligibility during the Great Recession, pre-ACA, versus 58% in more generous states for Medicaid eligibility. So matches up really well with what we found. And so what are the implications of this? Even before the pandemic, North Carolina had over 200,000 people in the coverage gap, meaning that they made too much to qualify for Medicaid, but not enough to qualify for subsidies in the marketplace. And perhaps not surprising, given everything that I've told you, the uninsured rate in the state rose to approximately 20% during the pandemic. So Medicaid expansion is a key piece to ensuring access to healthcare during public health and economic crises. And hopefully this data is going to be useful as another feather in the cap of pushing towards Medicaid expansion in the state. Thank you very much. And I will pass it over to our final speaker of today, Samantha Audi.
Great, thank you so much. I will do my best to follow up those impressive presentations. Today I'm going to be presenting some work that I've done with Paul Schaefer and Kevin Griffith, examining the impact of Medicaid subscription payment models on access to hepatitis C medications. Oh, there we go. So the number I'm going to start with is $3.2 billion. In 2018 alone, state Medicaid programs spent $3.2 billion on hepatitis C medication, which accounts for about 6% of gross spending, but only 0.02% of prescriptions. Hepatitis C is a largely curable bloodborne infection that attacks the liver and leads to significant morbidity and mortality if left untreated. And more than 4.1 million individuals have hepatitis C in the United States. But very few gain access to it. Less than 20% of individuals are treated for hepatitis C, and this is largely because of cost. The list prices for these medications range from $25,000 to $95,000. And so despite us having an effective treatment to eradicate hepatitis C, there's a very large gap between need and access, largely because of the cost of these medications. Oh, I'm going to say next. Yep, perfect. Thank you. So Medicaid faces a unique challenge in the context of hepatitis C. They ensure a disproportionate share of individuals with hep C, but they face finite budgets. Often they can't ensure universal treatment access due to these budget constraints. So they use liver damage and sobriety restrictions, which limit access to treatment. This rations hepatitis C medications to those who are the sickest, leaving many who would otherwise benefit unable to access curative treatments. But despite these very prohibitive access restrictions, we still see massive increases in spending. In 2014, we saw a $5 billion increase in gross spending after these new direct-acting antiretroviral treatments for hepatitis C were introduced to market. And this growth in spending has continued in the last several years, thus constraining prescription drug spending while ensuring access has become a large focus of Medicaid policy. Next slide. Under most Medicaid payment arrangements, states pay for these drugs on a per prescription basis, wherein spending will increase concomitantly with use. An alternative payment model is subscription-based payment models, which are also known as the Netflix model. They were originally proposed as a potential solution that caps spending but increases access. So under this model, states gain unlimited access to hepatitis C medications in exchange for a lump sum of money, very much like you would gain unlimited access to Netflix in exchange for your monthly fee. So under these models, the incentive to ration access is essentially eliminated because after a spending cap, or after you sort of fulfill the amount you've paid for the number of prescriptions that have been prescribed, the marginal cost is essentially zero, which is that flat line after the spending cap in comparison to fee for service. Next slide. So our research focuses on 2 states that implemented modified subscription payment models in 2019. The modified subscription payment models are qualitatively similar to how the payment model was originally proposed, but follows a 2-part pricing model. So first, states negotiated reduced per prescription prices, and then second, they have a spending cap. So at that spending cap, which is tens of millions of dollars, the price of the prescription is zero after that point. So our aim was to examine the impact of this modified model in Louisiana and Washington, which implemented this in 2019 using synthetic control methods. And we use a publicly available data source, the state Medicaid drug utilization files, which are a great resource to look at Medicaid prescription drug use in the United States. Next slide. So this is, before I get into what we found, I do want to sort of talk about the historical access to hepatitis C in each state, which is important context here. In the year prior to the subscription-based payment model, Louisiana had very restrictive access for hepatitis C drugs. So they required severe liver damage and sobriety, whereas Washington had no access restriction during our study period. And so that might be sort of explain why we see this massive increase in Louisiana. We see a 535% increase in quarterly prescriptions, but very little change in Washington in the post period after these models were implemented. We have found that in other states that removed these access restrictions, they only saw roughly a 41% increase in prescribing in the year after this policy change, which suggests that while removing access restrictions may be necessary, they are not sufficient to produce such an increase in use. Next slide. So for policy implications, subscription-based payment models are a novel payment model that theoretically can increase access and may very well do. Our results suggest that states that historically limited access to hepatitis C treatment may see larger gains due to pent-up demand. So Louisiana removed access restrictions for hepatitis C alongside with implementation, whereas Washington had neither restriction. So they may have sort of churned through those individuals who knew they were positive in the year prior to subscription-based payment models, whereas Louisiana sort of had an attentive population that simply had been unable to access treatment. Nonetheless, these models suggest that sort of Don Berwick's triple aim of capping per capita spending while improving population health could be possible under a model like this, and future research really should look at the impact on downstream health economics, health spending and health outcomes with more granular data. Thank you. That's that research.
All right. Thank you so much to Sam and everyone for their great talks. So if you haven't already, if you have questions, please put them into the Q&A. We'll use the remaining time to get through as many of those as possible. And I will sort of moderate things. There was one question earlier in the chat that I think would be an easy one for Sarah to answer. Do you know of any work being done to change Medicaid language to include birthing people that do not identify as women?
So actually, definitely not an easy question to answer. And the answer is that states really differ on this. I mean, even in terms of whether they will pay for gender affirming treatments, states basically come in three categories of explicitly cover it, explicitly don't cover it, or abstain from providing any guidance whatsoever. And so I don't know the specific answer about like eligibility forms and all of that, but I would guess that it tracks similarly to those other variations in coverage policies. But I also would think that there a lot of health insurance forms still offer two gender options. So I'm not sure Medicaid programs are going to be more progressive than commercial health insurers. So I'm not sure. My guess would be it's not a common practice.
Thanks for that. All right, here's one in the Q&A for Nicole. Many states with 1115 demos approved for work requirements were also approved to waive 3-month retroactive coverage. Our own state of Massachusetts has had a waiver of 3-month retroactive eligibility since 1997. Is the lab aware of any evaluation in the past 23 years of this feature? How about that as a research topic for the lab?
Thank you. It's a great question and one that's near and dear to my heart. Paul and I have actually written about this in a health affairs piece, and I think it's worth noting what the theory is behind allowing states to waive retroactive eligibility. The theory in a universal coverage place like Massachusetts is that if everybody is playing by the rules and getting insurance when they need to get insurance, then you don't actually need retroactive coverage because there's a safety net no matter where you turn. And so I think from a philosophical perspective, it is not necessarily inherently problematic to eliminate retroactive eligibility if you're in a true universal coverage place. However, one thing that's happened over the last several years is that the states that are getting waivers that permit elimination of retroactive coverage are states that are trying to limit access to Medicaid in a number of other ways, and they are trying to take a more punitive approach to Medicaid and trying to make it so that people treat Medicaid like commercial coverage. And that is not what Medicaid was designed to do. It's actually contrary to the purpose of Medicaid, in my view, to allow that approach. However, it started, frankly, during the Obama administration because there was such a desire to get everybody on board with Medicaid expansion. And so we saw a number of red states getting this kind of waiver in that time period, and it continued during the Trump administration. Paul and I have actually tried to get grants on this topic. Paul, I don't know if you want to jump in here, but I think it's worth saying a few words.
Yeah, happy to. Yeah, and I put a link in the chat to that health affairs blog piece that we wrote last year. I think this has been an area of Medicaid policy that just hasn't gotten very much attention. And I think with how the ACA and Medicaid expansion was originally conceptualized with the individual mandate and universal Medicaid expansion, you could make an argument that perhaps we wouldn't need retroactive eligibility anymore. But in practice, that didn't happen, and we still have these huge coverage gaps and people churning in and out of coverage. And of course, with policies like this, of course, there have been such limited evaluation of it, as you note. I think primarily because CMS and states don't put out, there's no required data reporting on how much this benefit is being utilized, how much it's costing, who is using it. So we have been trying to get some funding to explore this and do state public records requests to all 50 states and try to collect this data, as well as do a bit of evaluation of the Iowa waiver, which was the first of the recent examples of this policy, but we have not been successful as of yet, but hopefully we will be in the near future. I mean, one good thing is the landscape seems to have shifted, obviously, and with the Biden administration, it's hard to imagine that more retroactive eligibility waivers will be approved, but the ones that are in place are still there, and there hasn't seemingly been any discussion of getting rid of those the same way there has been with work requirements and other things. So it'll be an interesting space to watch.
Let me just say one thing about that, which is that if you read the letters that have been sent by the Biden administration to the states where work requirements have been rescinded, they sort of hold on the remainder of the waiver. And some of those waivers actually do contain this waiver of retroactive eligibility. And so I think we can expect to see further action by the Biden administration on the waivers that included work requirements. It's just that work requirements have been carved out for now. And those letters are quite remarkable because they are footnoted to the teeth. And the footnotes are full of the kind of data that we've all been talking about today. It includes my New England Journal piece that I just mentioned. Our colleague Julia Rafeman is cited in there. The kind of work that everybody here is producing is cited in these letters to the states, basically saying for all of these reasons, what you're doing is contrary to the evidence. And so I take heart from the evidence-based policymaking that appears to be occurring in these letters. So just throw that out there.
Great, thanks. Next question, Sam, why were Louisiana and Washington specifically chosen?
I'm sorry, I did not get to that in the talk, but Louisiana and Washington are the only two states who have been approved to implement subscription-based payment models. And so state Medicaid programs are actually prohibited from negotiating with a single drug manufacturer. Normally they have to cover a wide number of drugs within a certain drug class. So this is a large departure from Medicaid drug policy, and they needed approval from CMS to do so. So just Louisiana and Washington have implemented these models at this point. And then I think you have also had a question about hepatitis C prevalence, which I'll try to answer quickly. The short answer is no. There's very bad estimates of prevalence and disease burden generally. The best way to figure that out would be to use TMSIS data in the future, but I think the issue right now is that it's very, very under tested to begin with. And so the CDC is sort of the authority on what hepatitis C prevalence looks like in the United States, and their estimates are widely viewed as underestimations as well. And so in terms of what share of the Medicaid population has been treated, it varies state to state, and that data has not been published. So I'm sure states know, like I'm sure Louisiana and Washington know how many individuals they needed to treat, but that data is not publicly available.
Okay, thanks. Related to the data piece, for the data sets that we mentioned, can we talk about which ones have data on children and adolescents? Maybe Sarah, do you want to talk about TMSIS?
Yes, so national claims data typically obtained from CMS. You can request data on children. The large multi-year data set of pregnant women that I have actually does not include children, but I have children in other all-payer claims databases from Colorado and Utah.
And I'll just add, most of the data sets that I use on FQHCs include children, and all of the all-payer claims databases include children as well, and a lot of the survey data that we have.
Right, and HCUP, the healthcare cost and utilization project from ARC, which is essentially hospital discharge data, would also include children and adolescents as well. All right, we've got a couple of questions, both sort of circling the same topic. How can we help students get involved in Medicaid research, and how are we going to conduct ongoing engagement with the community in terms of workshops and seminars beyond our monthly lab meetings at the moment? I mean, those are great questions. And Sarah and Megan, feel free to jump in. I think by virtue of being at the early stages, I think we're still finding our sea legs and figuring out how best to engage with the community. I would say for anyone who's interested in this work, whether you're a BU student or not, please reach out to us. We provided our email and the website link earlier in the session. Particularly if you are a BU student, we'd be happy to add you to our listserv, and you can come attend our monthly meetings. We typically do updates on different projects that we're doing. We always have research in progress talks showing things that folks are working on, ways to engage on upcoming public comment periods, and so on. I don't know that we have a set plan at this point for future workshops and seminars, but I think certainly as we get closer to the fall semester, we'll be planning some other events. All right, and looking for any other questions no other questions in the Q&A, and just some wonderful thanks in the chat. We really appreciate everyone coming. We're right at the top of the hour, so this works out really well. I know I won't speak for the rest of the group, but I know I'm personally very amazed and encouraged by the great response we've received to the idea of creating this new Medicaid Policy Lab at BU. It's been months of work in the process, but it'll be really exciting to see where it goes from here, and we'll be so excited to form new collaborations with all of you and do work that is very powerful for moving the Medicaid program forward.
Thank you everyone for tuning in.
Thank you.
Thank you.
Thanks everybody.
And we'll be posting a recording of this, so if you have friends and colleagues who can make it that will want to take a look at it, we'll make that available afterwards. All right, thanks and have a great day.